It strikes me every time the way you have to completely shift your approach when caring for a tiny infant versus, say, a teenager who's practically an adult.
Oh, absolutely.
It's not just about, like, scaling things down.
No, it's fundamentally different. We're talking about bodies and minds that are just constantly changing, constantly developing.
Exactly. It's this whole landscape we have to navigate.
Precisely. And it's such a fascinating process, really. Physical growth is, it's just one piece of the puzzle, isn't it?
Right.
We also see these incredible leaps in how children think, how they interact, with the world and other people, and even how their sense of right and wrong takes shape.
And they're all connected.
Deeply intertwined, yeah.
Yeah.
They unfold in these, predictable ways mostly, though every child is different, of course.
And that's really the core of what we're digging into today. We've got some really foundational work here. Piaget, Erickson, Kohlberg, the big names in child development. And our goal is to take these powerful theories and show you, especially if you're a nursing student listening, how they directly inform what you do. When you're assessing and caring for pediatric patients.
Right.
We're looking at the whole journey, really,
Yeah.
from birth right up to young adulthood, maybe age 21 or so.
And our mission isn't just to, define the stages. It's to equip you with a deeper understanding of why age-specific care is so critical.
The why behind the what.
Exactly. Recognizing where a child is developmentally gives you such valuable insights into their reactions, their needs, and ultimately how you can give the best, most effective, and frankly, most compassionate care to them and their families.
Yeah, hopefully we connect some dots today, make some aha moments happen.
That's the goal.
Okay, let's start with something really fundamental, how kids make sense of the world. Jean Piaget's theory, his cognitive development stuff, gives us a really helpful roadmap here.
It really does. It's all about how they're thinking, perception, reasoning, problem solving, how all that evolves.
What I find insightful is how Piaget saw kids as active learners, like little scientists, right?
Totally. Constantly constructing their understanding through interaction. His stages aren't just about knowing more stuff. They represent these, qualitative shifts in how they think.
And for nurses, that's huge. It affects communication, care planning, everything.
Absolutely key.
So let's start at the beginning, sensory motor stage, birth to about 2 years. What are the key cognitive things a nurse needs to be watching for?
Well, in this period, infants and toddlers are primarily learning through their senses what they see, touch, taste, hear, smell, and through their motor action.
Reaching, grasping.
Exactly. Crawling, eventually walking. And a huge achievement, really monumental, is developing object permanence.
Ah, yes, the understanding that things still exist even when you can't see them. Peekaboo is serious business.
It really is. It marks a massive cognitive leap.
Okay, so practically speaking, for a nursing assessment, what are we looking for related to these traits?
We're observing developmental milestones. Are they tracking objects visually, reaching out, grasping, starting to sit, crawl, maybe walk? And for object permanence, simple games work, like show a toy, then hide it partly or fully. Do they look for it? That tells you something.
Right.
We're also watching that early parent-infant interaction, looking for bonding cues, and thinking about how sensory stimulation in their environment can actually support cognitive growth.
Can you walk us through a quick example? How would a nurse actually assess object permanence, and why is that specific milestone important?
Sure. So imagine you're showing, say, a 6-month-old a bright rattle. Get their attention, then maybe cover it with a cloth.
Okay.
An infant who's developing object permanence will probably try to pull the cloth off or look for the rattle.
Because they know it's still there.
Exactly. It signifies they understand the rattle hasn't just vanished into thin air. Delays here, along with other sensorimotor milestones, could be an early flag for potential developmental issues, needing more assessment. It tells us about their emerging understanding of how the world works, its stability.
That makes perfect sense. Okay, moving on. Pre-operational stage, ages 2 to 7, roughly. Big changes here.
Oh yeah. Now we see symbolic thought emerging. Kids start using objects, actions, words to represent other things.
Like pretend play.
Exactly. That's the bedrock. But their thinking is also, pretty egocentric.
Hard to see things from someone else's point of view.
Very difficult. And there's magical thinking, too, believing their thoughts can cause things to happen in the real world. Their logic is still very tied to their own immediate perceptions.
So if you're a nurse dealing with a preschooler, how does that pre-operational thinking shape your approach? Assessments, explanations.
You have to recognize their understanding is going to be very literal and, frankly, self-centered. Explaining procedures needs care. This is where play becomes incredibly valuable. Using dolls or puppets to demonstrate what's going to happen. That can really help them process information without feeling threatened.
So keep the language simple.
Absolutely. Clear, simple, direct language. Avoid abstract concepts they just aren't ready for yet.
Give us a specific example, explaining something simple like maybe getting a shot to a preschooler, keeping that egocentrism in mind.
Okay, so instead of saying, this medicine will help your immune system fight the infection, which is way too abstract.
Right, means nothing to them.
Exactly. A nurse might say, maybe while showing a colorful syringe, this special medicine will help you feel better so you can go back to playing with your toys soon.
Focusing on a tangible outcome related to their world.
Precisely. It addresses that what's in it for me perspective that's so typical of egocentrism at this age.
That's a really helpful distinction. Okay, next stage, concrete operational. About 7 to 11 years old. What new cognitive tricks do they have up their sleeve now?
So this is where logical thinking really starts to kick in, but it's still largely tied to concrete things they can see, touch, manipulate.
Not abstract yet.
Not really abstract, no. But they develop conservation, understanding that quantity stays the same even if appearance changes, like pouring water into a different shaped glass.
Right, the classic Piaget experiment.
That's the one. And reversibility, the ability to mentally undo an action.
So for nursing assessment and patient education, how can we use these developing skills?
Well, we can more directly check their understanding of cause and effect. Visual aids become super helpful now.
Like diagrams.
Simple diagrams of the body, maybe charts explaining how a medicine works. And importantly, we can start involving the child more in decisions about their care. Offer choices where it makes sense. They can grasp more concrete consequences now.
Fosters cooperation.
Definitely. Gives them a sense of control.
How might a nurse use a visual aid, say, for explaining a medication schedule to a kid this age?
You could create a visual schedule, maybe with pictures or simple words for different times of day. Then use stickers to show when each med needs to be taken.
Makes it concrete.
Exactly. It's a tangible plan they can understand and follow, leveraging that logical thinking.
Got it. Okay, last one for Piaget. Formal operational stage. Starts around 11, continues on. What's the big leap here?
Abstract reasoning. That's the key. Hypothetical thinking. Thinking about possibilities, what-ifs, and deductive logic. They can grapple with complex theoretical ideas now.
So how does this ability for abstract thought change how nurses assess and interact with teenagers?
Well, now we can really assess their understanding of risks, long-term consequences of health choices, treatment plans.
Crucial for things like managing chronic illness.
Or sexual health, substance use, absolutely. We can involve them in more complex future planning about their health. But we also have to be sensitive to their emotional maturity, which is also developing, and make sure they're truly active, informed participants in decisions.
Can you give an example? Discussing long-term implications with an adolescent, say, for a chronic condition.
Sure. Instead of just listing facts about, let's say, diabetes management, a nurse could have a conversation about how keeping blood sugar controlled helps them achieve their goals.
Like playing sports.
Right. Or pursuing a certain career, or just having energy for friends. It connects that abstract idea of long-term health to their own concrete aspirations and plans.
Makes sense.
And, stepping back, what's really powerful about Paget's framework is how it lets nurses tailor their whole approach.
Yeah.
From explaining a simple procedure to encouraging someone to take their meds, you match it to the child's cognitive level. It just works better, improves understanding, builds trust, reduces anxiety.
It's really about meeting them where they are intellectually. Okay, let's pivot now. Erik Erikson's theory of psychosocial development. This shifts the focus to how our social interactions shape our sense of self.
Right. Exactly. Erikson really zeroed in on these psychosocial crises or conflicts that we face at different stages. Successfully navigating these helps build a healthy identity and emotional well-being.
Each stage has a challenge.
A unique challenge, yeah. And as nurses, understanding these helps us provide more developmentally supportive care.
Okay, stage 1. Trust versus mistrust. Birth to about a year. What's the core conflict, and what should nurses be assessing?
The fundamental task for an infant is developing basic trust. Trust in caregivers, trust in the world.
How does that happen?
It comes from consistency, having their needs met reliably, feeding, comfort, affection. So nurses should assess the parent-infant interaction, look for signs of secure attachment. We also monitor feeding patterns, how the baby responds to soothing, and just the overall consistency and responsiveness of the caregiving.
What are some practical things nurses can do to actually foster that trust in an infant during care?
Gentle handling is key. Responding promptly to cries and needs, having predictable routines helps a lot, and actively involving parents in comforting and feeding. Also, minimizing painful procedures when possible, and always providing comfort afterwards that really contributes to building that foundational trust.
Makes sense. Okay, next stage. Autonomy versus shame and doubt. Toddlerhood, maybe 1 to 3 years. What's the driving force?
Independence. Toddlers are on this quest for control over their bodies, their environment.
The me-do-it stage.
That's exactly it. Think toilet training, feeding themselves, exploring everything. The conflict happens if their attempts at autonomy are met with too much criticism or control. That can lead to shame, self-doubt.
So what should nurses look for when assessing toddlers?
Well, readiness for toilet training is one. Their motor skills gross and fine, language development, and importantly, finding ways to offer them choices, supporting their independence safely.
How could a nurse support that autonomy during something stressful, like getting a vaccination?
Instead of just, holding them down, offer a choice, even a tiny one. Do you want the Band-Aid with the dog or the cat?
Gives them some feeling of control?
Exactly. Even a little bit helps. And praising their cooperation, even if it's brief, reinforces their sense of competence.
Good tip. Okay, on to initiative versus guilt. Ages 3 to 6, preschoolers. What's the focus here?
Preschoolers get more assertive, imaginative. They're eager to take on new things, mostly through play and interacting with others.
So initiative.
Right. The challenge is encouraging that without making them feel overly guilty if they mess up or, overstep boundaries.
What do nurses assess?
Observe their pretend play, their language skills, their eagerness to start tasks. And we can use role-playing to help them prep for procedures. Let them act things out in a safe space.
Can you give an example, using play therapy maybe before a minor surgery?
Sure. A nurse might use a medical play kit, doll or stuffed animal as the patient.
Uh-huh.
Let the child use the toy instruments, safely of course, to examine or treat the doll. Act out the steps. It helps them get familiar, express anxieties, and feel more in control.
That makes sense. Then we hit school age, industry versus inferiority. Roughly 6 to 12 years old. Main task.
Learning and mastering new skills. In school, socially, they're developing competence, looking for approval from peers, adults.
Industry. Building things, achieving things.
Exactly. Feelings of inferiority can pop up if they constantly feel like they're failing or not measuring up to their peers.
So nursing assessments should look at
School performance, social involvement, overall self-esteem. And we can encourage their participation in their own care, maybe have them help chart their fluid intake or something simple.
gives them a sense of accomplishment.
Right. Fosters that sense of industry, responsibility.
How can a nurse boost that sense of industry if a child has a chronic illness that maybe limits some activities?
By focusing on what the child can do, celebrate those achievements. If kid with asthma is great at tracking their peak flows, acknowledge that responsibility, that competence.
Set small, achievable goals related to their care.
Perfect. That builds mastery.
Okay, next up is a big one. Identity versus role confusion. Adolescence, 12 to 18.
Absolutely critical stage. It's this intense period of exploration. Who am I? What do I believe? Where do I fit in?
Trying to form a coherent sense of self.
Exactly. Values, beliefs, future goals. Role confusion happens if they struggle to get a clear, stable sense of identity.
What do nurses need to be especially sensitive to?
Body image issues, peer relationships, emotional ups and downs, respecting their privacy is huge, and involving them as active partners in health decisions is absolutely paramount.
What about discussing sensitive topics like sexual health with teens? Any specific considerations?
Creating a safe, confidential space is number one. Build that trust.
Okay.
Provide accurate, unbiased info in a way that respects their developing identity and potential anxieties. Let them ask questions openly without judgment, and just be mindful of potential discomfort. Tailor your communication.
Right. And finally for Erickson, intimacy versus isolation. Young adulthood, maybe 18 to 21.
The main task here is forming close, meaningful relationships, developing that capacity for emotional intimacy.
And if they struggle?
That can lead to feelings of isolation, loneliness. So, nurses working with young adults should assess their social support systems, their coping skills for stress, the quality of their relationships. And since this is often a time of big life changes, discussions about reproductive health navigating the adult healthcare system, those are important too.
How might a nurse assess the social support for a young adult just diagnosed with a chronic illness?
You could ask open-ended questions. Who do you feel you can rely on? How has this diagnosis affected your relationships? Understanding their support helps us see if they need extra resources to avoid isolation.
Yeah.
So you see, Erickson's theory gives us this really powerful lens for the psychosocial journey. Our nursing care needs to support them through these stages, fostering not just physical healing, but a strong sense of self and healthy connections too.
It really drives home seeing the whole person, not just the diagnosis. Okay, let's shift gears one more time to Lawrence Kohlberg's theory of moral development, how our sense of right and wrong evolves.
Yeah, and what's key with Kohlberg is his focus wasn't so much on the choices people make, but the reasoning behind them.
The why again.
Exactly. His theory suggests this sequence of stages, moving from morality based on external consequences towards more internalized ethical principles.
Okay, his first level,
Yeah.
pre-conventional, ages 4 to 10 generally.
Huh.
What's moral reasoning like then?
It's mainly driven by external rewards and punishments. Stage 1, obedience and punishment, is basically don't do it or you'll get in trouble.
Simple enough.
Stage 2, individualism and exchange, is more about self-interest. What's in it for me? Like a fair exchange.
How can nurses use this understanding with kids this age?
Well, positive reinforcement rewards, praise, can be really effective for getting cooperation.
Stickers.
Stickers work. Explaining rules simply, focusing on immediate consequences, positive or negative, is helpful. And watching their play, how they handle fairness in games, gives you clues too.
Can you give an example? Encouraging a young child to take medicine using a reward based on this level.
A nurse might say something like, if you take all your medicine like a superhero, you get to pick a cool sticker afterwards.
Appeals directly to that reward desire.
Exactly. Frames taking medicine as the way to get the positive outcome.
Okay. Next level. Conventional. Usually preteens, early teens, maybe 10 to 13. How does moral focus shift?
Now they start internalizing society's norms and expectations. Stage 3, good boy, nice girl, is all about gaining approval, being seen as good.
Wanting to please people.
Right. Then stage 4, law and order, shifts to respecting rules and authority to maintain social order, doing your duty.
How does this affect nursing interactions and education for this age group?
We can reinforce positive health behaviors by praising their efforts, framing it as being responsible or helpful. Peer influence is bigger now, so group education or activities can work well, and clearly explaining the rules and reasons behind treatments resonates with their growing sense of social responsibility.
How could you maybe use peer influence to encourage treatment adherence in a preteen with a chronic condition?
Well, if there's a support group or maybe a peer mentoring program for kids with the same condition, encourage participation.
Hearing from others going through it.
Exactly. Hearing from peers who are managing it successfully can be a huge motivator, appealing to that desire to fit in and be seen as responsible by their group.
Makes sense. Okay, finally, the post-conventional level. If reached, it's usually adolescence, young adulthood, 13 to 21 or so. What's reasoning like here?
At this level, people move beyond just accepting rules. They start considering abstract ethical principles. Stage 5, social contract, recognizes laws are agreements for justice and rights, but they can be questioned or changed.
Thinking more critically about the rules.
Right. And stage 6, universal ethical principles, is guided by one's own deeply held principles, justice, equality, human dignity, even if they conflict with laws.
So how do nurses assess and interact with teens who might be reasoning at this level?
We need to assess their capacity for abstract thought, ethical reasoning. When discussing complex treatments, we can facilitate conversations that explore the ethics involved: autonomy, beneficence, justice. Encourage them to consider different perspectives, how their own values inform their health decisions.
Can you give an example? Discussing ethical considerations of a treatment choice with an older teen.
Okay, say an adolescent with a serious illness has a choice between 2 treatments, different benefits, different side effects.
Right.
A nurse could help explore the ethical implications of each choice based on the teen's values, their idea of quality of life, and their right to make informed decisions about their own body.
Having a real nuanced discussion.
Exactly. Understanding Kohlberg's stages helps us appreciate their developing moral compass. It lets us explain rules and care expectations in a way that actually aligns with their reasoning level, which fosters better understanding and cooperation.
Okay, this has been incredibly insightful. Let's try to synthesize this. Can we do a quick summary of key nursing assessment priorities for each age group, pulling from all these theories?
Sure. For infants, 0–1 year, key priorities are assessing attachment, response to sensory input, established routines, parent-infant bonding, and how they respond to soothing.
Got it. And for toddlers, 1–3 years.
Focus on observing and supporting that drive for autonomy, feeding, dressing, etc. Monitor motor and language development. And provide simple choices whenever possible within safe limits.
Preschoolers, 3–6.
Use play. It's their language. Offer simple, concrete explanations. Encourage their desire to be helpful and involved in age-appropriate ways.
School-age children, 6–12.
Involve them actively in understanding and participating in their care. Explaining procedures, maybe tracking symptoms. Pay attention to their school, social, and emotional development that's central to their sense of self then. Industry versus inferiority.
Right, exactly. And adolescents, 12–18.
Respect their privacy and confidentiality, huge. Be attuned to identity exploration, potential risk-taking. Recognize peer influence and emotional shifts, and treat them as active partners in health decisions.
Finally, young adults, 18–21.
Assess their readiness for independence in managing health, their adherence to adult health roles, and the strength of their psychosocial support systems as they navigate that transition. Plus, things like reproductive health, understanding adult health care.
Wow, okay.
Ultimately, weaving these developmental theories into nursing practice just gives us a much richer, more effective way to care for kids and young adults.
Yeah, it's not just seeing a medical condition.
Right. It's seeing a developing individual with unique cognitive, psychosocial, and moral viewpoints that deeply influence how they experience health and illness.
Exactly.
Wow.
By consciously thinking about these stages during assessments and interventions, we deliver care that's not just age-appropriate, but really personalized, tailored to the specific needs of that child, that family.
This whole framework really shifts our perspective, doesn't it? We see the child not as just a mini adult, but as this dynamic person on a unique developmental path. And that influences everything, how they see their illness, how they engage with care.
So for everyone listening, especially nursing students, as you move forward, keep these theories in your back pocket. When you interact with a pediatric patient, ask yourself, what developmental stage is this child likely in right now? And how can that understanding fundamentally shape how I communicate, how I plan care, how I support their overall well-being? It seems like a simple question, but thinking about it can have really powerful implications for providing truly patient-centered care.